everybody, Dr. Anna Moran here. I'm presenting on behalf of my colleagues Dr. Susan and Dr. Kristy Robson. I led this study on behalf of Services for Australian Rural and Remote Allied Health, or SARA. Our study was commissioned to look at the influence that scholarship support had on achieving some of our big, hairy, audacious goals that we have for rural allied health, and that is to ensure that the distribution, supply and retention of allied health professionals is appropriate to meet the needs of our rural communities. So like I've said, we have a big hairy problem, and our big hairy problem is that there are high levels of morbidity and mortality in rural communities. We know that allied health professionals can contribute towards improving this problem, but there's not enough of them, and they're not distributed appropriately according to those communities most in need. So our big hairy audacious goal that we're all talking about at this conference, and we're all talking about the ways that we can achieve this, is to ensure that there are sufficient AHPs to meet rural needs and that rural communities thrive. But I wanted to make this point that this big knot in the middle are all the different ways that we can try and unpack this problem and address it. And each single time we try to unpack and address the problem, it leads to a small shift in the way that we are trying to achieve our big, hairy, audacious goal. So in this study, we tried to unpack this knot just a little bit to examine the contribution that scholarships made to achieving our big, hairy, audacious goal, but not necessarily all the other known factors that we know go into this big mix and help us to work towards some solutions. So in a nutshell, like I'm saying, the big hairy problem has a number of small problems, and each small problem has an activity that you can use to address it, or an intervention or a solution. And then we need to know what the impact of that is on solving this smaller problem here. And altogether, when we look at a number of these different problems, and this presentation will go through 5 of those, hopefully when we break down the problem into small components, we understand the activities that address them and the impact those have, we can start to get a picture for how we're going to achieve our big, hairy, audacious goal, which is to improve the supply and retention of AHPs to rural areas and to see rural communities thrive. Okay. So on to what the big activity was that we were looking at, and that is the Nursing and Allied Health Scholarship and Support Scheme, or the NAHSSS, and it ran between 2011 and 2017. Sarah was the administrator for the Commonwealth Department of Health for these scholarships. In total, over 4,600 scholarships were awarded. There were 5 scholarship streams and over 23 different allied health professions. Now, these NAHSSS scholarships were intended to support AHPs to obtain, retain or extend their qualifications, and we were tasked with understanding the impact, or I'd rather use the term the influence, these scholarships had on exactly this. And then we were tasked with understanding the influence that or those activities had on achieving our big, hairy, audacious goal. So as you might know, the workforce pipeline has multiple different components, and they're kind of bunched around these different components here. There are many more. I'm sure I've missed some of these components, but just to point your attention to all the different things that might contribute towards achieving our big, hairy, audacious goal, this is where the activities that we examined fit into the picture. So we looked at how these 2 elements or scholarship streams influenced supply, how clinical placements influenced supply and attract, and how CPD and postgraduate scholarships influenced retention. We used multiple different sources of data. We did an evidence review, which I'll go through very briefly in this presentation, and I urge you to read through the full report, which is available at SARA. We looked closely at scholarship commencement data. There was a lot of data there, as you can see, and it was to do with the demographics of the different cohorts of scholarship streams, and in particular we were interested in their modified Monash model geographic location at commencement of their scholarship. We then surveyed everybody in a follow-up survey and asked them questions about where they are currently now and the impact that the scholarship had on them. And then we ran some in-depth interviews with participants from each of the scholarship streams. As you can imagine, there's lots of different components to this, and as I've tried to describe, there are multiple different ways to unpack this big hairy problem that we have. So we used an applied program logic framework to unpack the different problems, the outcomes we were trying to achieve, and then to understand how each of those different components may have an influence on the supply and retention of the rural allied health workforce. So just a quick overview of how we did that. We identified what the desired outcomes were. We identified indicators that would help us know when we'd achieved that desired outcome. We looked at the problems that were standing in the way of achieving this. We then looked at the evidence-based enablers and contexts that we know we can put into place to help us overcome some of these problems and achieve our desired outcomes. And then we looked to see whether or not those activities, in particular the NAHSSS scholarships, had an impact on the desired outcome. So over to our evidence review, and please see the full report for all references. I haven't put them all on this slide. But my main point here is to point out that on this workforce pipeline, there are multiple different components that either singly or together contribute towards improving our movement towards our big, hairy, audacious goal. So we know about rural origin and the influence that that has on the supply, attraction and retention of the rural allied health workforce, thanks to Playford's work and lots of other contributors. I just wanted to point out the whole list of evidence that we looked at very briefly to understand what all the enablers might be to help improve the supply of allied health professionals. And I'm going to just quickly click through them here. And again, I urge you to read the report. We've summarized them in a really nice program logic table for you there. But these are all the evidence, and noticed at the end that I've put a plus sign. And that means that we're not sure what order these need to go in, what the most impactful enabler is to influence the supply of allied health professionals, and we're not sure how many of each of these needs to go in the mix to move towards our big, hairy, audacious goal. So I wanted to point out that there's quite a number of enablers there. We know that there's some other enablers here around attracting rural allied health professionals to work in rural areas. We also know that there are a number of elements that need to be adhered to both attract and retain staff. Attract and retain are on a very similar pathway, and these are just some of the elements that need to be in place in order to retain staff in rural areas. And again, we're still not sure whether these have to be done in order or what strength each of these individual components has, but we're still coming to that conclusion. And finally, the last one to point out is work is being done in this area. And it's really that we can't actually have a really comprehensive pipeline until we are very clear about what the needs are across Australia and for different rural communities. And that certainly influences how we distribute and also how we plan for the supply of the workforce. So there's work to be done in terms of understanding which of these elements is the most important, which is most weighted, which is going to be most impactful to achieve what we want to achieve, but also to understand how a system might work that brings all these elements together. So as you can see, it's a big, hairy problem, multiple moving parts to solving this problem, and lots of great work has been done to examine a number of these enablers. Now, our contribution to this today is simply to look at how the scholarships have contributed into these. So just briefly, these are where we believe these scholarships fit in terms of the known enablers that help to work towards the impact and the outcome that we want. So kind of a small contribution, but a contribution nonetheless. Let's look at the undergraduate scholarship stream now. So again, using our program logic framework, this is how we approached evaluating the extent to which these scholarships influenced our big, hairy, audacious goal. You can read these here. In particular, the ones in bold are the activities and contexts that we know from the evidence that will help us to address the problem. And these were certainly part of the undergraduate scholarship program. You had to be from a rural area, and the scholarships themselves help to financially support students to attend and complete their allied health degree. So let's look at the impact that this made on those scholars. 880 scholarships were funded, and most of those scholars have completed their undergraduate degree and obtained their registration. So a large supply of allied health professionals into the workforce over this last 10-year period. The NAHSSS funding had a significant impact on their financial ability to attend university and complete their undergraduate degree. On follow-up, even more impressive is that 2/3 of those rural origin undergraduate students have chosen to and are currently working in rural areas. Looking at our clinical placement stream now, again, this is our program logic framework that we use to understand the impact that these scholarships had on those big audacious goals. You'll notice here that of all the evidence-based enablers that could have been in place that might have made this successful, rural origin wasn't one that was part of the selection criteria. Whilst it was used to some extent to screen applicants and positively award those two students from rural backgrounds, it wasn't intended to just focus on rural students. So what impact did we see? We saw that over 1,395 clinical placements were funded, and 100% of those placements were carried out. Scholars were predominantly from metropolitan backgrounds when they received their clinical placement. A lot of them identified it absolutely enabled them to do the rural clinical placement in the first place, where financially they wouldn't have been able to afford that. I just want to point out that whilst this last statistic is fantastic, that 44% of those who replied to the follow-up survey from an MM1 background were now working rurally, what a number of the scholars identified, particularly those who were from metropolitan areas and who stayed in a metropolitan area, was that it gave them a wonderful exposure to the issues that you see in rural areas, to rural clients, and that's enabled them to be better practitioners in their metropolitan practices, and some of them are now providing outreach to rural services, particularly after COVID. In terms of the clinical psychology stream, you can read through here what we were trying to achieve, and these activities on the right hand side of the screen are those that are evidence to help influence both the obtaining of those degrees but also the retaining of these professionals in rural areas. You'll notice again that rural origin is not highlighted here. It wasn't targeted specifically as part of these scholarships. However, when there was a huge influx of applications for the clinical psychology scholarships, they were screened according to rurality, and it was positively awarded to those who are from a rural origin. And a bit of background on these clinical psychologists, in order to obtain that endorsement to practice as a clinical psychologist in that specialty area, require a master's, and then they also need to undertake supervision to achieve that. So these scholarships were enabling part of that, which was to undertake that master's level study. So what impact did they have? Well, we saw over 550 scholars were funded through this stream. Of those that followed up, pretty much all of them had graduated from their funded study and had obtained their endorsement. There is an alignment. Sarah did collect data on who graduated from and obtained their data, and the alignment with that 552 scholars awarded is accurate. Most of those have completed their studies. One problem that stood in the way for these guys, however, was trying to find a supervisor to help them with their clinical supervision, which was part of the accreditation and endorsement process. A number of those that we interviewed, and certainly the open-ended feedback in that questionnaire that we sent them at follow-up, indicates that whilst the funding allowed them to pay for and take time out of work to gain their accreditation and their masters, it didn't fund the cost of clinical supervision, which was also a requirement, and that's in our recommendations around what that might need to look like in future. We also know that they were very grateful for this funding. It definitely helped them to achieve their endorsement. And finally, that about 50% of them remained working in a rural area where they were from a rural area in the first place. The CPD scholarships, really, they're there as part of that retention piece, and we were looking at providing means to undertake professional development, which not only helps those in rural communities to have the skills to address particular community needs, but also allows them to have enhanced career opportunities. As you can see on the right hand side, these scholarships were targeted at those from a rural origin, and those 3 dot points there is what the scholarships were trying to achieve. What impact did they have? 925 CPD scholars were funded. They overwhelmingly reported that not only did the NAHSSS have a significant impact on their development of skills, it could help them to address areas of need in the community. A large proportion who commenced their scholarship in a rural area remained in a similar rural location, which helps us with our retention piece. The postgraduate scholarship stream here is our program logic to help us to understand the impact that these scholarships had on that big, hairy, audacious goal, and pointing out here that the activities and contexts that have been evidenced to enable retention of rural health professionals are here. These scholarships targeted rural origin AHPs, and these 4 dot points down the bottom here. In particular, it's the career advancement opportunities, but also looking at our desired outcomes. We really wanted these health professionals to be able to have the skills to meet their community needs. So what impact did this have? A significant number of scholars were funded to undertake postgraduate study, of which most of them had completed their study. Over a third of these scholars identified that it enabled them financially to complete those studies. In terms of the retention piece, most postgraduate scholars who were working in rural locations at the beginning and when they received their scholarship were still working in rural locations afterwards. So, in summary, we saw 1,452 allied health professionals enter the workforce because they obtained their allied health qualification. We saw 1,396 students supported to undertake a work integrated learning placement in a rural area, which we know is a contributor to the attract stage of working in a rural community. We saw 1,790 rural AHPs supported to undertake CPD or postgraduate study. And overall, we saw 71.9% of rural background scholars continue to practice in a rural area. Were the scholarships successful in trying to meet the big, hairy, audacious goals? These are all the different success factors that we have demonstrated progress towards in this study. You can read through those at your leisure, but they're a summary of all of the impacts that I've just presented. We know that rural origin students are more likely to return to rural practice, and by targeting the rural origin and rural workplace allied health professionals and students, the NAHSSS scheme has really successfully enabled that a contribution towards the supply and retention of AHPs in rural areas, and the statistics back that up, although I have to say it needs a little bit more massaging in the stats machine to make sure that we can demonstrate that before and after effect a little bit better. And obviously recognising that all the scholarship streams didn't target rural background students and allied health professionals, but those that did were highly successful. So how could the NAHSSS be improved? We want to see that the NAHSSS, and this talks to the geographic distribution component of this study, we couldn't demonstrate that there was a positive change in terms of the geographic distribution from where the scholars were when they received their scholarship to where they are now. And this is because whilst the scholarship stream tried to target particular professions and particular areas of study that the government had identified were kind of in need professions or in need areas of skills and capability, there wasn't a sufficient level of baseline data that enabled us to understand the areas of need over here were met by this scholarship scheme. And that's because we really actually have no baseline information on what the areas of need are in our rural communities and the extent of that. But the good news is that there are some people working towards this right now. So my former business colleague, Professor Susan Nankaro, who also contributed to this study, works now with a fellow called Peter Bell. They help to run this geospatial insights around the needs of the community in rural areas. This unpacks exactly where the demand and the need might be for services, and they can overlay that with where allied health professionals and other health professionals are, so we can really understand where the supply of professionals needs to go to meet needs. And that needs to be part of this broader argument around how do we actually systematically train the types of professionals to match the areas of need and then distribute them to those areas of need. So that's a piece of work that's currently being undertaken and needs to be explored a little bit further. Finally, allied health careers have absolutely blossomed under the NAHSSS. There's more work to do. I'm just identifying 3 schemes here that are currently at play that are helping with the attract and retain component of these big, hairy, audacious goals. And this is my last point. As I've said, these are all the variables that we looked at very broadly in our evidence review. There are far more than this that go all the way along the workforce pipeline. We need to be able to look at which of these activities or contexts are the strongest influence on the supply and retention of the rural allied health workforce. And we also need to work out whether they need to be done in order, or if they don't need to be done in order, which one is most impactful and what are the other contexts and enablers that need to come around that key enabler in order to achieve the outcomes we want to achieve. So there's a bit of work to do, lots of ingredients in the soup, and we probably need to just sift through that soup a little bit more and identify what are the most impactful ingredients and start to then have a systematic way of influencing our supply of allied health professionals, the distribution of those into those areas of need so that our rural communities thrive. That's it. You can get the full report from Sarah. These are all our references again, they're at the end of the full report, and you can also contact me if you need me. Thanks for listening.